We're good to go.
Yeah, okay. Yeah, good evening, friends. Welcome to our Tuesday masterclass webinar. So actually, this is focused mainly on the students. It contains the regular expert guidance, all senior consultants and examiners who are involved, and the students present on this platform. They get a very good insight, and these lectures are recorded versions, and most of the students, they have given feedback that they go back to they revisit these webinars during before exams, and they are very helpful. And across other clinicians also, like especially tier 2 cities and all, they follow these webinars very regularly. They had given a feedback. It helps them in their clinical practice. So with this, today's topic of discussion is toxidromes and OP poisoning. As everybody know, we day in and day out as a critical care physician deal with these type of patients. Sometimes you may not be knowing unknown poison consumption by any patient, where thorough history, clinical manifestations, and focused approach, toxidromic approach is very important. And OP poisoning per se, being agricultural background in India, so we do see a lot of these patients regularly. So that is the reason one should be able to know thoroughly about what is OP poisoning, how to deal with it. So with this background, we'll go forward. I welcome our expert examiners today. Dr. Anand V Joshi, sir, is a senior consultant, critical care medicine from Sydney, Australia. Sir also worked in India. So regularly he comes to our platform and provides a very good expert guidance. We always look at him for thorough learning and good concepts. Welcome you on board, Anand sir.
Thank you, Kaladhar. It's always pleasure coming back and discussing. You are always learning everything, and as you grow in your career, you learn more from your residents and registrar rather than and the patients, of course, rather than anybody else. So thanks for having me.
Yes, sir. And I welcome Dr. Pragyan Kumar Routray, sir. Sir is joining. So he is also senior consultant, head of the department at Care Super Speciality Hospital, Bhubaneswar, having vast experience and dealt with these cases very regularly. When I was in care, we used to be in touch regularly with Dr. Pragyan. Dr. Pragyan, welcome on board.
Thank you, Dr. Kaladhar. Wonderful. It is. I think it's my second sitting with your academic session. It's a wonderful to be part of it. Let's carry on. Let's start.
Yes, yes. So today's case to be presented by Dr. C. Goutham and Dr. KLVN Veni. Both are DrNB critical care medicine students from KIMS Hospital, Secunderabad. Dr. Goutham, you can proceed. Yeah.
Yeah. Good evening, sir. Yeah, we are going to present a case of a OP compound poisoning. Yeah, coming to the case, we had a 26 years old male who was a resident of Hyderabad who presented to us on 20th April at around 6 p.m. The presentation history was like multiple episodes of vomiting with pungent smell and diarrhea, multiple episodes since morning. So then we inquired about the family members and they admitted that he has consumed around 40 ml of monoprotophos at around 3 p.m. that day. He was then immediately rushed to our hospital.
Primary survey in ear on examination, airway, there is drooling of saliva present. Breathing, the patient is breathing. There is rapid shallow breathing with a saturation of 91% and 5 liters of oxygen support. Circulation, heart rate is 38 beats per minute. Sinus bradycardia. BP is 85 by 60 mmHg. Peripheries are cold, pulses felt. Disability, patient is drowsy but is responding to pain. Bilateral on examination, pupils are pinpoint and sluggish reacting to light. Exposure, there is a strong pesticide smell coming from the patient and the undergarments are soiled with feces and urine. There is excessive sweating also noticed. The random blood sugar at this time is 170 milligrams per deciliter.
And we inquired about his previous comorbidities and also his past medical history. He was not on any medication support, or there is no, and also we inquired about history of any co-ingestion with alcohol. But the family members said that he did not take any alcohol. Like there was no co-ingestion with the OP compound, and he had no, he has no comorbidities. And coming to his medication history, he is not taking any other medications.
This is the ABG of the patient in the ER. the interventions we did after the initial examination was patient was then immediately intubated with 8-sized oral cuff endotracheal tube. Prior to that, we have given atropine because of the sinus bradycardia and hypotension. Atropine initial bolus dose was given. Atropine was given till we have achieved the atropinization, which is attained at a dose of 40 milligrams. This is followed by a infusion 10% of the atropinization dose of 40 milligrams per hour. Since there is a hypotension also, we have resuscitated the patient with IV fluids, and then intubation was done simultaneously with 8-sized oral cuff endotracheal tube fixed at 22 centimeters mark. Since there is a clear-cut evidence of OP poisoning compound, we have started the patient on praldoxime also. We have given 30 mg per kg IV bolus followed by 500 milligram per hour infusions. Bedside 2D echo was normal. The cardiac function, ejection fraction and cardiac function was good. ABG, there is a severe acidosis. This ABG is prior to intubation. There is a respiratory acidosis with retention of PCO2, and there is a history of vomitings and diarrhea also. So there is hypovolemia also. So there is a mixed metabolic and respiratory acidosis pattern seen in the ABG.
Chest X-ray we have done, we noticed that there are bilateral hilar opacities noted, and then he was then shifted to our ICU. After atropinization, his heart rate was around 110 beats per minute, with infusion continued at 4 mg per hour actually, and blood pressure was 116 by 76 millimeters of mercury. Saturation was 96%, requiring an FiO2 of 0.7 with PEEP of 10. Still secretions were present and bilateral Krebs were noted. In the meanwhile, his labs were hemoglobin 14.2 grams per deciliter, white cell count of 9,600, and serum creatinine of 1.09. Electrolytes, sodium, potassium chloride 136, 3.9, and 103, and his LFT were within normal limits.
Anand sir and Pragyan sir, do you want to interrupt and ask any questions at this point?
Yeah, I mean, the family came and told you that he had consumed monocrotophos.
Sir, they have brought the bottle, sir, actually.
Yeah, agree.
Yes, sir.
They had not bought the product. How would you approach?
Like we go with a like toxin. There is a clear history of some poison injection. Like suppose we go with this case with like a toxidromic approach. We'll go, sir. Like we will have that constellation of signs and symptoms, and based on the signs and symptoms, we'll go whether it is a sympathomimetic poisoning, the most common what we see like anticholinergics or the cholinergics or any serotonin syndromes, or any alcohol or any sedative hypnotic poisoning, sir. So as this case, generally we'll go with the vital signs like central nervous system, and we will examine the pupils, and we will observe the skin color and the next blood pressure.
Okay.
And also
sorry, let me interrupt you there. A 26-year-old male comes to you in a subconscious state with vomiting and diarrhea.
Yes.
So you will go with the toxidromic syndrome?
No, sir. The other differential diagnosis to be taken like any seizures, gastroenteritis,
Correct.
vomiting and diarrhea followed by drowsiness, hypotension. We have to think of other causes also, sir.
What are the other causes?
Seizures or any gastroenteritis.
Vomiting, diarrhea, and it's a straightforward, right?
food poisoning.
Food poisoning.
Straightforward things are common. Just because you have got this thing, because somebody told you, because you have this, so you are considering in that aspect. I'll come to that later, how you should approach in general also. And you should have. It told you, suppose something has been taken, right? And then how would you approach? So there are three aspects of it. Yeah? One is the history aspect of it. Second thing is a clinical features aspect of it, and silence. And in history, I will let you know how you would approach later. You need to keep all the things in the mind, because when you are sitting in a casualty, of course, you won't be sitting in a casualty. The ER person will be sitting in a casualty. But you should also have inclination to revisit the history again. Okay, phone ochindi from ER, they have called from some acute gastroenteritis has come, and they will shift in and will continue with the acute gastroenteritis. So you are here highly relying only on what the ER person tells you, right? When is the last time you have actually met again and taken the history of the family? Very less time. After hours, never. It's only next day morning when we realize that something is not working, and then we go back and start taking the history. Right? By that time, the crucial time is lost. Correct? So the approach, when you guys saw this patient before, there has to be a method to overcome these hurdles, right? Because today is the toxidromic discussion, because this today is so because that it's an OP poisoning, because all these things, it becomes very easy. But in real life, it doesn't work like that, right?
Yes, sir.
Go ahead.
Patient continued on atropine at 3 mg per hour. Heart rates are around 100 beats per minute. Pupils 3 mm reacting to light. Temperature of around 99 degrees Fahrenheit. On auscultation, bilateral air entry noted and bibasal crepes are present. FiO2 reduced to 50% on P5 with a PaO2 by FiO2 ratio of 200 mmHg. The pseudocholesterol levels, which was sent on day 1, came as 990 units per liter. Artifeeds were started and thromboprophylaxis started.
On day 3, we were able to taper atropine to 1 mg per hour with targeting a heart rate of around 90 to 100 beats per minute, and temperature was 99 degrees Fahrenheit, and pupils were 3 mm reacting to light. Bilateral air entry was present. There is a leukocytosis with WBC count of 15,600 cells per ml, and chest X-ray was showing right lower lobe consolidations.
On day 4, patient was tapered of atropine. Weaning from ventilator started with pressure supportive ventilation. Heart rate of around 97 beats per minute. Temperature normal. Lung fields clear. Patient irritability came down. He is conscious and obeying commands. And praldoxime stops.
So we continued with the weaning from the ventilator. On day 5, patient on spontaneous breathing trial, it failed, and we noticed there was proximal muscle weakness, and he is unable to hold his head for more than 10 seconds. So in the view of possibility of intermediate syndrome, patient was continued on the mechanical ventilatory support, sir. So this was the ABG taken on the SBT, sir. With there was a CO2 retention with PCO2 of around 62.5.
On day, the chest X-ray was resolving. Blood and ET cultures came out negative, sterile. Pseudocholesterol levels started improving with around 14,000 units per liter. Patient underwent tracheostomy in view of prolonged ventilator support.
So then he was shifted to high dependency unit on day 10, and we weaned him from ventilator over the course of next 5 days. He was decannulated on 8th May at around 2 weeks approximately from the day of admission, and he was discharged in a stable condition to home on 10th of the May.
How do you define intermediate syndrome?
After the initial stage of cholinergic crisis is over, there will be a new onset of muscle weakness, sir, mostly involving proximal muscles. This is causing respiratory paralysis. This is due to myopathy, injury of the muscles because of the cholinergic poisoning, sir, OP poisoning.
Is there any
last for 2 weeks?
in the definition, is there any time period given that after this it is mainly the intermediate?
Yes, sir.
1 to 4 days, sir. The duration will be 1 to 4 days after the OP poisoning, sir.
For intermediate syndrome? Why it is called as intermediate?
First one is the cholinergic crisis causing muscle paralysis, sir. Second one is the intermediate syndrome. So third one is the delayed neuropathy will come, sir. So it comes in between these two.
Goutham is saying
So-
intermediate syndrome is from 1 to 4 days.
Yes, sir. 1 to 4 days after the
Cholinergic
cholinergic
crisis
crisis.
is over, sir. Like cholinergic crisis
4
set
days
it.
of cholinergic crisis is over. So
Cholinergic
that
crisis
is
set it. Yes,
usually that comes onsets from
day 4, around day 4, sir.
usually comes after 5 to 7 days. Right?
Yes, sir.
Makes sense?
Yes, sir.
Yeah.
Yes, sir.
Oh, what was the final diagnosis for your patient?
Final diagnosis will be organophosphate poisoning induced cholinergic crisis causing leading to mechanical ventilation, followed by intermediate syndrome, and then prolonged ventilation, tracheostomy, and then recovery, sir. Then
You won't be writing so much in the discharge summary, right? You'll be writing final diagnosis. What will you do?
OP, intermediate syndrome, OP poisoning with intermediate syndromes.
Why was he hypoxic? Hypoxic, right? You have to
Initially, there was
Was he hypoxic, by the way?
Yes, sir. He was we received him with 5 liters oxygen support, sir. On that, he is maintaining 92-94 saturation, sir.
So was it
He is
hypoxic?
hypoxic.
Or not a hypoxic?
He is hypoxic, sir. Yes, sir.
What would be the causes of hypoxia in the OP poisoning?
for any co-ingestion with other substances like alcohol, sir, which will cause us like respiratory depression and any seizures and pooling of the secretions causing bronchoria, bronchoconstriction.
Anything else?
Bronchoria, bronchospasm, decreased central also, sir. Decreased respiratory rate, muscle paralysis, respiratory muscle paralysis.
Okay, come out of this toxic syndrome. Forget that he had taken something. What would be the cause of hypoxia in this kind of patient who has come drowsy, was vomiting? You said, no?
Yes.
Hypotension.
Is vomiting, there might be aspiration causing bronchospasm, sir.
Why bronchospasm? Aspiration won't cause hypoxia?
Yes, sir. Yes, sir. Aspiration.
Was there aspiration on your patient?
Yes, sir.
What made you think that?
He came with pooling of secretions in his mouth. While intubation also, we are able to see a lot of secretions.
You only told, na? Your X-ray showed
Vomiting is the
consolidation.
history of
You only told, na? Your patient had right lower zone consolidation on
Yes.
X-ray.
Yes.
That's aspiration, na?
Yes.
So final diagnosis will be OP poisoning complicated by aspiration pneumonia.
Yes.
There
Right.
are answers coming from even our participants here, like low
Yeah,
G.
and everyone is saying that. Yeah. So that's the thing. What are the factors that will determine that this person is likely to get intermediate syndrome?
Compound, sir, it is a monocrotophos, which is a dimethyl compound, sir.
Why does intermediate syndrome otherwise occur? What is after the chronic crisis is gone? You were saying something. What happened? What?
persistent inactivity of the cholinesterase enzymes.
Participants are answering. I'm not sure whether you guys are able to see.
Persist.
What is the specific thing concerning about this organophosphorus poisoning in your initial approach? A, B, C, D, E. What is thing which you should keep in mind that, and how is the absorption occurring? How does the storage occurs? And why we need to know this? Okay, I said this was not an intermediate. I would say it was still OP poisoning. Will I be wrong? Because he went home on what? He came on, he went home on 10th.
Yes.
So how many days total? 15 days he went home.
20th he admitted, sir. 20 days.
15 days he went home, na?
20 days.
20 days, 15, 20 days. So that brings down to the same question. What are the factors you should be considering? Why cannot this be a still? I think participants have already answered that. Why cannot this still be a plain, continued, prolonged effect of OP poisoning? What are the factors that you should consider? What was the BMI of the boy? What was the build of the boy?
He's inbuilt only, sir. 65 kgs, around 65 kgs.
So basically, this OP poisoning has a propensity to get into the fat and then start getting released, and then they keep on continuing releasing, and hence
I think we got an answer. Somebody told that it's fat soluble. I think one of the guys have answered that is a fat soluble poison. That is why intermittent syndrome happened. I think while you were asking, somebody replied that.
That's what I said, that they are not reading the. There it's been answered, right? And they are easily absorbed through the skin, and hence you actually smell OP poison. If you have really treated them enough, you can actually smell those kind of, right?
Yes.
So let's focus on OP poisoning for now, and then we will go for the general approaches. So when these are the factors you need to keep into consideration from the therapeutic point of view. Many a times they wake up and get up. There is a fat person coming in, taken little bit or some half amount, he wakes up because it's a volume of distribution is high. You feel he's okay, extubated, goes home, goes to the ward, collapses. Think that it's an intermediate syndrome. It may not be intermediate syndrome. It's still the poisoning which has gone. Because you need to continue giving the atropine in one case, and in intermediate syndrome, it's mainly the supportive care. Right? The reason you need to know this is because the treatment aspects are completely different on those aspects.
Yes.
Go back to your treatment. Back. Day 1, day 2, day 1. Yeah. Okay. Started on atropinization and pralidoxamide.
So before that, just Dr. Anand, can I interrupt? Just let us ask him.
Please.
So sorry, Dr. Anand. Just one question in between. Dr. Goutham and Dr. Veni, am I audible?
Yes.
Yeah. So tell me, what is your first approach? Let us say you are in ER or patient straight away came, as ER was loaded, patient straight away came to you. So you have, as Dr. Anand told very nicely, you are smelling OP poisoning. Tell me the approach. What are you going to do now? The patient is just carried into the bed, bed number 2 of your ICU. What are you going to do? So you are second year or third year DNB student? Sorry to interrupt.
Third year, sir.
Third year. So you're going to appear examiner. So I'll ask exam related questions. What are you going to do? First, patient is just wheeled inside.
Yes. bradycardia and hypotension are there, sir. First you give atropine, sir, and then
Excellent. So
oxygenate
somebody-
the patient.
Just one, Dr. Sriram, one of your
This is a very practical thing.
attention
You have a patient built in.
is a
Yes.
we need to take care of the personal protection first, no? So as
Yes.
it is very contagious, as Dr. Anand told, it is very contagious. So personal protection is the first thing to be done. Eh? Somebody answered very nicely. That's a very, very first thing. Then, of course, you'll be taking care of the patient, personal protection. So if you're going and jumping into doing CPR, then there's going to be trouble because it is highly contagious. No, so that is a personal protection first step.
Yes, sir.
Then carry on. Then what will you do?
We will start immediately with go hand in hand with we'll start atropine, sir, first. Oxygenation. Next, we will take care of the circulation also, sir. We have because already.
So being an examiner, I'll ask you that I'm the father of the patient. I told that patient had taken OP just 2 hours back. Oh, can I do? I'm a doctor. So can you suggest? Can I suggest a gastric lavage for my son? Like a father, if I'm a doctor father, I'm asking whether gastric lavage is indicated here or not. Next question.
Sir, no, sir. Generally, because as a patient is hypotensive and his GCS is very low at this point, I cannot advise gastric lavage in this case. And also, generally, gastric lavage has advantage when it is done within 1 hour, sir. So, on these 2 points, I cannot advise the gastric lavage to this particular patient, sir.
What if he has taken
Okay.
a polypharmacy, it's an unknown poisoning, or what if the patient has taken something else? Or it has taken co-ingestion?
No, sir. As he's unable to protect his airway in this case, sir. So I cannot go with gastric lavage, sir.
Then you intubate and do the gastric lavage. You take care of the airway, then do.
Yes, we can intubate the patient and we can do.
Actually, I wanted them to say. It's
sorry,
so
sorry,
the way I would have put the question. Yeah, the way I would have put the question is so you will leave in that.
Sorry, Dr. Anvia, carry on. Take.
You told the answer. No,
yeah.
So what is more important here? To leave his airway unprotected. So you are yourself are saying that its airway is unprotected. He has aspirated. So first year approach, ABCD, this thing is there, right? In resuscitation, you protect the airway, no?
Yes, sir, we'll protect the airway.
Wait and then
Coming to
proceed with
point
the
2, you
lungs.
told that you are going to atropinize. Please define atropination. How are you going to do atropination?
Initially, we will give a 2 mg doses, first bolus. Then we will we'll wait. We'll double, sir, the next dose till the signs of atropinization, like heart rate more than 100, secretions clearing off, lungs clear. We'll give the next dose, the double the previous dose, sir. We'll keep
What is the
on
difference
giving.
between the time difference, ma'am? Time difference, Dr. Veni. First dose, then after how much time I'll double the dose?
5 minutes, sir. 5 minutes.
Okay. So what will be your leading criteria? Like you told, heart rate more than, what do you want to target? 80, 100, 120, what is the target?
100, sir, at least 100.
Okay, great. Number 2?
And secretions clearing off, sir. Oral secretions and lung crepitations, airway clearing off, sir.
So chest clear. Absence of bronchospasm and
Yes,
chest.
yes.
Okay.
Yes, sir.
What else? What else?
These 3 are enough, sir. No need of dilatation of pupils.
Okay. Okay. Let us say somebody chest is clear, but heart rate is still 80. Whether you would like to increase the atropination or you have to stuck it over there. Heart rate is 80, but chest is absolutely clear. You find a dry skin, a dry tongue over there. What is your target? You sometimes the points might differ. No, the 3 criteria you told, they might differ. They may go haywire. Somebody might be having a heart rate of 140, but secretions will be very high. Somebody might be having a heart rate of 80, but secretions are dry.
Heart rate of
You're getting
80,
one,
we can accept, sir. 80 to 100 heart rate with clear chest, we can accept, sir.
Do you
answer that
do you
question
know?
is my target will be
know any-
secretion. Yeah.
Yeah. Do you know any what we call it as a slogan or a saying or a mnemonic for this, for a signs of atropinization?
Mad.
I don't know.
Mad as a
Your generation knows this story. It's an English story. The movie was made.
Mad as a hatter, hot as a hair.
Hot as an hair,
Blind
blind as the bad as a
blind
hatter.
as a blind.
There's a sign
Red
of
as-
organization.
Red as a beetress.
Dry as bone.
Okay, so yeah,
Red
great.
as-
So that is the sign of atropinization. You have to build it to the extent. And why you want to do that?
to prevent the and muscarinic effects. Anti-muscarinic effects we are doing, sir.
Correct. So what is
Okay, after
not
that,
covered in that?
yeah,
What is
so
not
after
covered?
yeah, please, Anand, continue. Dr. Anand, continue, sir. Continue.
No, sorry, we are overlap. No, you continue. I think
Yeah,
we
so
are
after
asking
that-
the same question.
After initial bolus dose, so what is the plan? How you are going to continue atropine? Initial bolus you have given, you got a
10%
dry chest.
Yes,
Yeah,
sir.
tell me.
10% of the bolus dose will maintain as a infusion, sir.
Okay, and targeting the same three things that you have told, correct?
Yes, sir.
Correct. Dr. Anand, anything about atropine? Otherwise, then we'll go to PAM. Anything regarding atropine you would like to close?
Yeah, I think we should go to correct. So remember the science of atropinization, it's a non-negotiable thing. You need to know the science of atropinization. You also need to know what is an atropinization chart. If you go in a periphery or if you worked in a peripheral government hospital, there will be an atropinization chart where you have to record specifically. And you don't have to, you have to instruct the nurses to record these things. Okay. So the atropine is important, first dose, correct, but you need to know the science of atropinization from examination point of view. You cannot fumble on that.
Next, coming to palidoxime. So, what is the plan you told us? You have given PAM. So, what is the dose you have given? And tell me whether PAM is evidence-based or you are giving whimsically, or what is the PAM? What is the evidence behind PAM? Palidoxime, I mean. And what is the dose you have given?
As per the WHO protocol, sir, we are giving palidoxime, sir.
Yeah. So, what is the dose you have given in this patient?
30 milligrams per kg IV, sir, followed by infusion with 500 mg per hour.
500 mg per hour till, or you are going to continuously give, or you are going to give intermittently?
No, sir. Bolus we will give, sir, for 48 hours. Sir.
So, bolus you are giving 30 mg per kg. After that, 500 mg per hour for continuously, or intermittently 6 hourly, 4 hourly. Because that's
No,
2
sir,
or 3. Sorry.
Continuous we are giving, sir.
Okay, I'll ask the members who are attending, if you have any difference of opinion that you can put up your answers. Dose of PAM. We are waiting for you. Number one. Number two is, so is there any indication of PAM regarding patient presentation? So like that, when PAM should be given, whether patient presented within 6 hours, 12 hours, 48 hours, what is the best way of giving PAM so that we'll have good results?
Within 1 hour, sir.
And why? And why?
And why? And why? Correct. Great. Right.
Within 2 hours is best, sir. After that, aging will occur, sir. So even there might not be much more beneficial effect if we start late.
Define aging.
After the binding of the organophosphate to the enzyme, there will be a loss of alkyl group and it become irreversible inhibition, sir.
How long it takes? Approximately.
Aging occurs with this monocrotophos. It occurs very fast, sir. 2 hours, within 2 hours. Dimethyl compounds, sir, monocrotophos.
Right. And do all the organophosphorus compounds require palidoxime?
Diethyl compounds, but they are aging late, sir. So more beneficial in them, sir.
No, sorry, let me put the question another. My question was wrong. does organochloride versus organophosphorus? Which one you will use? Redoxam and atropine, which one you will not? It can be organochloride also, right? Organochloride is also used. Not everything is not organophosphorus.
Carbamates, they don't age, so no role of praldoxam in them.
Organochloride, organophosphorus, and organocarbamate. These are the three compounds. There are three distinct compounds.
Yes.
Right. One is useless, one you are useful, and one you don't.
Carbamates, it is not useful.
Phosphorus, you use it. Now coming back to sir, what he has asked. What's the evidence? Because you need to know this evidence.
Yeah, this will be
Consider.
asked to DrNB, no, finally it will be asked. Might be missed in IDCCM, but the last two are the
One of
evidence of
the-
palm, whether palm should be given. Yeah.
And this is particularly true because the study was from India. Study was from India.
From Pune,
One of
Maharashtra,
the-
Lancet published one praldoxam continuous infusion. There is a study published in Lancet, sir, in 2006, done from Maharashtra, where it is found to be beneficial.
Correct. Yeah, but there was another bigger study done. But bottom line is equivocal. There is no superiority. But if you don't give it, that should be all right. That's what it concluded. Right? For how long the praldoxam you will be giving?
48 hours.
Anything else?
Only thing regarding the study, actually, you should always quote the JV Peter study. That is the most famous study regarding PAM. The Indian study, always quote that. Praldoxam is actually a little bit controversial. Majority, it is, if you will, as Dr. Anand told, so majority thinks that it should not have been given. Then you have to tell me why praldoxam came into dispute. What is the major side effect of praldoxam? That is why it comes to. If it would have been a safe drug, everyone would have given. So what is the side effect of praldoxam?
Praldoxam itself is a partial agonist, sir.
Okay, so what it can cause?
It itself can cause cholinergic symptoms.
So majority is cardiovascular side effect and can cause
Yes. Yes.
Yes, the cardiovascular could cause majorly cardiac side effects. It can cause sudden cardiac effects. So that is why. So you have to be very careful while we're giving. So give it in infusion. You should avoid any sort of. You have to give it in a slow graded doses. Okay, that's why. And coming back, last Dr. Anand discussing about intermediate syndrome, he told very correctly. It usually happens in the second week, most common. Textbook says that it can happen after 4 days. So like old examiner, if you say that it is happening within 4 days, they'll be a little bit astounded. That is why Dr. Anand asked repeatedly whether it is a continuation of OP poisoning disease per se or say intermediate syndrome. If you say that somebody having intermediate syndrome day 4, you will be taken into task. Okay. So usually intermediate syndrome happens mostly commonly on the second week only. After 5, as Dr. Anand told, 4 days is quite early. All the textbook says it can happen after 4 to 5 days, but 7 is there is the right thing actually. So then again we'll go back to the same question where we left out. So is there any treatment difference between acute poisoning and intermediate syndrome? That thing we midway lose the discussion. So what is the treatment? What is the treatment of intermediate syndrome?
Supportive care, we have to protect the airway and we have to stabilize the patient.
Okay. Anything else?
And prevent the secondary infections.
Okay. Is there any role of same again going back to an atropine or palm, anything like that? As what is the reason of intermediate syndrome? As we discussed, drugs are again released back from fat to the blood suppression. Do we need to repeat atropine, etc., or we are okay with supportive treatment only?
Usually atropine is not required. Supportive treatment itself is enough.
Good, right. So main respiratory support is usually required, and that's a tricky question. That's why you'll be trying to answer that we might repeat, we need not repeat. We'll only continue the respiratory support and supportive treatment, and that's right. And coming back to the what we are discussing, what is the difference of treatment between carbamate and organophosphorus, organochlorine and organophosphorus treatment difference?
Carbamates generally they will cause reversible inhibition, sir, of the acetylcholinesterase enzyme, whereas phosphorus they will
Okay.
cause irreversible. Sir,
Okay.
they will cause irreversible enzyme inhibition. So the reactivation of the enzyme will take much more longer time in organophosphorus poisoning, sir, compared to the carbamate poisoning.
Okay, great. Dr. Anand, over to you. Anything you would like to ask?
Yeah. So same. I mean, coming back to this intermediate and the prolonged thing. That's the reason you need to know the initial history and the demography and co-consumption and how the patient is, like a fat or a thin or this thing. This will give the prediction whether he will have a continuation things. A fat person coming to you with unknown quantity taken is likely to have this slow continuous release of the thing, release of the organophosphorus compound, and in which case you will have to keep treating it with the atropinization. Suppose even after 7 days he continues to be weak, in that it will be like a continuation thing. Then you need to continue atropinization. In that case, if you say that no, this is 7 days have passed, is still there, so it is a intermediate, then it becomes very confusing. So this is a very gray area. There is no specific demarcation to say. Hence, the overall assessment of the patient becomes very important, whether to continue atropine or not. Definitely not pralidoxamine. You don't do for 7 days. That is for sure, right? So all these things should be on the tip of the tongue, and your viva should get over within less than 5 minutes when it comes to OB poisoning, right?
Okay,
Sir, with your permission, I just wanted to share few slides, if it's okay.
Okay, sir.
Everybody able to see the slides?
Yes, sir. We are able to see your slides. Yeah.
Yes.
Right. Okay, so why we call these as a toxidromes, especially when you need to understand that this is what actually you come across when you sit in an ED. You don't know what toxic substance has been consumed, and hence we go as a syndromic approach, and hence they are called as toxidromes. Broadly, you look for the features which are cholinergic and anticholinergic. Both are on the opposite side. Look for a very hyperthermic things like stiffness and all those things, which include neuroleptic malignant syndrome, serotonin syndrome, or sympathomimetic. So these are just broad classification. There are a few more, but this is where most likely you will fall in the category. This is a very cheat sheet which will give a brief description. I understand it is practically impossible because we don't come across with these kind of things daily. But this you will get it one page ICU.com. It is very nicely given, and it is very pocket and ready reckoner, which will give you an approximation that what things are there, right? History remains very, very important in these kind of things. The demography also remains very important in these kind of things. So temperature is there, dilated pupil, constricted pupil, increased tone, decreased tone, dry, wet, sweaty, all those things, hyperactive person, or is there in diarrhea, where there is catatonia, there is a clonus, all those things will help you to differentiate. But they will be fitting in 2, 3, or 5 of these kind of things. So this is how you go and approach. Now, even with all these things, there will be a delay in the people getting the things to you. You don't know whether he has taken polypharmacy, you don't know you have taken any multiple substances. So you need to form your own approach where you don't miss anything, right? There is one approach which is quite popular among the registrars in Australia, and they go by this mnemonic RSI dead. Okay, so whenever you come across in an emergency department, you follow this tick mark so that you don't miss anything as far as poisoning is concerned. Okay, so RSI means double R is first is the resuscitation. So first and foremost thing, you don't sit and look for the anything else. You don't look. First, you resuscitate if patient is hemodynamically unstable. You look for airway. Any threatened airway, you don't wait for anything or think of anything. You just tube the patient, right? Then breathing, circulation, disability and exposure. Now, exposure here becomes very important, especially when you are organophosphorus poisoning and all those things. You need to wear your PPE, yourself PPE, and have a proper soap and water washing. So that becomes an important. And this is a history you need to see, ask the ED people also that whether they have done it or not. So it becomes very important. Suppose a patient comes into the cardiac arrest and you have a strong suspicion that this is a poisoning. Remember that when you start a CPR, you should anticipate that this person, see, any poisoning will have a half-life and it will eventually get metabolized. So this person is likely to survive if he continues to perfuse his brain and his heart. So when this person, if you are in a places where you a higher institution, where you have all the access facility, then this patient will be kept on eCPR, where it will continue for 1 hour, 2 hour, 3 hour, 4 hour, or directly go take him to the ECMO and keep him survive. Because we know at the end of the day, somewhere something would be metabolized and he will survive all these things, right? So airway, breathing, chest compression and circulation, you have to keep these things has to be anticipated in advance. Not after 1 year of 1 hour or after 30-40 minutes, so we can't do. And then you go and ask for eCPR or you ask because every bigger thing like an ECMO or anything requires time for the team to get back to you, right? So you at least have to give them some time. Until then you have to continue the CPR. So you have to anticipate these kind of things and then approach your resuscitation. So this is a slightly different approach for resuscitation as compared to your otherwise general person. Early low threshold for airway protection, breathing, circulation, CPR, long CPR and the ECMO and exposure and cleaning yourself. Once you have resuscitated the patient, you have to think of risk consideration. Where is this person coming from? You are currently, you may not in the city get patient with a OP poisoning or drinking organophosphorus. They may come with polypharmacy, they may come with their grandmother's beta blockers, they may come with the aspirin, they may come with the paracetamol, antipsychotics, anything can be there. So you need to keep that thing in mind. Just because textbook and during our presentation it was a OP poisoning, we will be thinking on that. No. If he's not a farmer, what he will do? He's a techie guy. There was some problem with him and he took unknown amount of pill. So you don't know. He took 10, 15 tablets of something, various combinations. So you are in soup. You don't know what is happening. So demography of the patient is very important. Age group of the patient is also important. Accessibility of the patient is a person working in a pharmacy, person working in a pharmaceutical, in a hospital, whether there is a nurse, whether he's a nurse or he's a ward boy, or whether the patient is not related to pharmacy. What is the access for these drugs? Those things should rapidly go through your mind along with the history. Allergy is also important. One person knows that I've got an allergy with this. He consumes those things. He wants to commit suicide. That is also important. Suspected drug, whether it's an acute or chronic. Some people are chronic druggies, whether it's a cocaine, whether it's a narcotics and all those things. Depression is going on, whether they are taking this medication for a long time. Those things need to be understood and kept in mind. Polypharmacy, co-ingestion, what was the intent? Whether it was just a threatening, there's some, it is a 12th, and somebody has got less marks in 12 little bit, he just want to threaten, he actually doesn't want to die. So those things will also help us. If there's some intent is really, see, it is very difficult to commit suicide. So you really have to be very, very, very brave or mentally really unstable to commit that suicide. Otherwise, it's very difficult. So these things you have to, and time since exposure, which you have already mentioned, and look for the toxic effect. Once these two things are done, you have to go for the stabilizing the hemodynamic and organ support. Just many a times what happens, once ABCD is there, circulation is there, everybody goes away. Nobody is there with the patient except the poor little nurse who is standing there looking here and there what to do, right? So you need to come back and make sure that those hemodynamics are maintained, whether the vasopressors have been started, whether they have appropriately monitored, the monitor is fixed, it's working and all those things, and shifted to the ICU. So during transfer to the ICU also, transfer care should be taken. Otherwise, everything is stopped and the patient comes from ground floor to the 11th floor, and by the time it comes up, it's dead. So those are the things which you need to keep in mind. Third thing is the investigation. Basic investigations which you need to send, at least that will give an idea about your toxidromes, will be the CBC, there will be electrolytes, ABG will be there. Look for the anion gap, and look for the drugs which will cause high anion gap, metabolic acidosis, low anion gap, metabolic acidosis. Drug alcohol, drug paracetamol levels, suspected drug levels or serum tests like acetylcholinesterase, RBC, acetylcholinesterase level, all those things you need to send early, not after the patient has stayed in the ED for 6 hours waiting for the billing clearance and then go out. You have to take the blood and start the treatment. Urea, creatine, LFTs, CT brain. Don't forget about the trauma it has happened. If it was a suicidal intent, he would have taken all the poison and jumped from somewhere or banged his head. We don't know. So that also you have to take. There is one more important thing which I forgot to mention here is an ECG. Right? ECG, calcium blocker, beta blockers, SSRIs, antipsychotics, all those things will have this QT prolongations, torsades, and all sorts of arrhythmias. Those you need to keep in mind. Now, once RSI is done, you need to look for the decontamination, activated charcoal and bowel irrigation. As you rightly said just now, I will not give you activated charcoal if its airway is not protected. That is the first thing. To protect the airway and give activated charcoal if it's fits within the time. Now the thing is, there are few poisons. It's a reason which requires a multiple dose of activated charcoals. Some requires an extracorporeal or alkalization, extracorporeal plasmapheresis or extracorporeal heme adsorption for the toxidrome are very, very, very important in this kind of situation, which you have to keep in mind. Anesthetics, poisoning occurs or overdose occurs, then lipid emulsion therapy also you might get. Who knows, your colleague is depressed and he just takes up all the things. Then you also need to know that you haven't, because he wants to sure shot die. So you can always help him by using this lipid emulsion therapy. Majority of the time you may not know the antidote, but if you need to know antidote, you need to give an early antidote. And finally, you should close. It is your responsibility to disclose it to the family and reporting it to the police. So these are all a gross approach. If you follow this is a very popular approach down under, and majority of the people will have this kind of systematic approach. If you do for systematic approach, I'm sure you will not miss any of your poisoning case or any of your case where you don't know what poisoning is. That's all from my side.
I think wonderful presentation. I just say totally It is a very comprehensible form where you can do whatever required. No, that's very nicely presented, Dr. Anand. I think if we'll ask the delegates that are present whether they have any questions, otherwise we can close. Dr. Kaladhar, are you there?
Yes. Yes, sir. I think it was very nice, brief and crisp, and how to practically approach Dr. Anand sir for that brief presentation. And regarding actually one thing important to practically day to life, especially the patients who are presenting with organophosphorus poisoning, most of the times the attendants we face them, they will be asking whether my patient is going to be better starting. So the prognostication point of view, Dr. Goutham, do you want to tell how do you prognosticate these patients to their family?
Sir, like general TOX syndromes are coming to per se or OP.
Per se OP poisoning. Per se OP poisoning, particularly.
Sir, we have a like risk assessment score. We'll use Paradigm OP poisoning score we have. Sir. So based on that score, we can risk stratify them and we can prognosticate to the families. Sir.
So how do you tell?
How are you going to tell the family? Are you going to say that as per this scoring system?
Sir.
I don't know
No,
what they're going to look at your face and say. Enti sir, a scoring system.
no, sir.
They will not understand all those things. No? You have to tell, they will tell whether my patient is going to be okay. So how do you tell? What is the course and how do you tell? That's the most common thing that we face, and even during your exams, the prognostication point of view, you will be facing it. Should be able to tell it, yeah. Probably putting it in a layman terms.
So we will generally ask about the quantity of injections and duration of injection and what is the route of the injection. So based on these factors, whether it is a dimethyl compound or as we discussed diethyl compound, presentation to the ER, all these points. So if the patient is presented to us very late in the course and he's already hypoxic and he has got means the presentation to the ER, if it is like in a cardiac arrest state, no sir, we will prognosticate poorly to the family. Sir.
Anand sir, do you want to add anything? Dr. Pragyan or
I'm just giving a small scenario. Suppose a 72-year-old female with a BMI of 36, hypertension, diabetic, had a cardiac history, 2 stents on 20 milligrams of rosuvastatin, 75 of icosapent, 75 of clopidogrel, on a bisoprolol, on cardaron, comes to you with a OP poisoning, and she's in with you for say day 8 now, and she gets an UTI or she has an aspiration and the bug grows Klebsiella, which is resistant to all except aminoglycosides and colistin. So what are the things you will be keeping in the mind? So, and urine also grows candida sensitive to azoles. What are the things you will keep in mind while treating this patient of OP poisoning? You got all the things, right?
Age of the patient.
She is elderly, she is fat, she's got statins on board, she's got beta blockers on board, she's got fluconazoles on board, she's got UTI, blood which is growing some gram negative, which is sensitive to this. What are the things will go through your mind? That is this, are you concerned with this patient or what?
Mostly hospital-acquired infections, sir. Prolonged hospitalization, growing and everything.
In treatment aspect, what are the points you are worried about in this patient?
Multi-organ failure is a...
Okay. but you're
So
going to
we-
treat, right?
You have to remove the
How will
source
you-
of infection, sir. First point, first remove the source of infection.
Obviously, this is hospital acquired.
Hospital liquid. So we have to change the lines, any lines, and then
Then
UTIs.
give me the treatment chart of this patient. This is very practical, right? You will be writing a treatment chart of the. Tell me a treatment chart of the patient. Choose your antibiotic choice. I'll be happy. You choose any. Tell me 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is the patient. She's intubated.
UTI, MDR Klebsiella, sir.
Treatment chart.
UTI with MDR Klebsiella.
If it is like MDR
Treatment
Klebsiella,
chart.
What do you
Treatment.
want to start? Be specific.
It is sensitive. You got a sensitivity.
If there is synergism observed with ceftazidime avibactam and aztreonam, will go with ceftazidime avibactam and aztreonam, sir. If it is an MDR Klebsiella.
If I come in the next day morning and your treatment chart, there will be only ceftazidime avibactam written on that treatment chart. Nothing else will be written.
Sir, antibiotics, sir,
Antacids,
sir. Beta blockers for her hypertension. Sir. OP poisoning, he recovered, sir. Cholinergic syndrome, day.
It's
Day
day
of
6,
COVID.
day 7, day 8. Madam. He has taken a big amount of organophosphorus.
Then we will have heart
Tell
rate
me-
and BP targets.
No, that's what I'm saying. Na? So you tell me what you are going to write a treatment. Tell me the treatment of this patient. What you are going to
If
write? Take a pen and paper. Write the treatment. Number 1. What you are going to write? Number 1.
antibiotics.
Number 1 doesn't mean important. I'm just making a sequence. Number 1. What you want to write? What you will usually write?
Thromboprophylaxis, sir.
From fast track bits we will do,
Okay.
sir, first. So
Okay, fast
feeding,
track grading. Okay.
yes, feeding,
So you will
sir.
be writing in your treatment chart. You will be writing feeding first. Is it? So what
Care plan.
treatment? Depending on what you are going to write in treatment chart. Very easy. What you are doing daily. That's only I'm asking. I'm not asking anything else.
We had venous thromboprophylaxis, sir.
Thromboprophylaxis.
Okay. What you will write? What do you want to give there?
If
Based on serum creatinine value, we would start either heparin or Clexane, sir.
Okay, heparin added. How much heparin you want to give?
5,000 international units subcutaneous BD, sir.
Okay, subcut BD. Next, what you want to write?
Then antibiotics, sir, we want to write.
What antibiotic you want to write?
Sir, is it a UTI, sir? You said we missed it during
Is a
the question.
blood is showing gram-negative bacteria. Currently, sensitivity is only cholesterol and aminoglycoside.
Okay, sir.
Somebody has
Then
written something down in the group.
polymyxin,
I
sir.
agree.
Injection polymyxin, 7.5 million units BD, sir. 15
Okay.
lakhs bolus, 7.5 million units BD, sir.
Okay. Then
ulcer profile,
pantoprazole.
Yes, sir.
Next.
if she is in still cholinergic crisis, we
We
will
can
start
also
to
group
continue.
Candida vitamin.
Sir, urine grew
You can also
candida, sir, culture or microscope? CUV.
Culture, CUV.
CUV, we replace the folies and send the midstream urine sample again, sir.
Okay. Again came Candida.
Then we send for culture
We'll
or
add
growth,
fluconazole,
sir.
sir.
Yes, sir.
Okay, fluconazole, right? What else?
Yes, sir.
So these are the only 3 things you will be writing. heparin, pantoprazole, polymyxin. That's all.
Sir. Atropine, if
Atropine.
she is in
Pulmonary.
allergic crisis. Atropine infusion, sir.
Atropine infusion to continue. Then
Yes, sir.
with heart rate 110. Then
No, sir. Heart rate will target around 80, sir, for this patient.
okay, 80 to 100. Okay. Then
Yes.
If she's
Statins will stop, sir,
why?
because the statins cause muscle weakness, sir. She is already OP poisoning.
The thing I wanted to convey to this is, what are the drug interactions that going to mimic your intermediate syndrome that will be introducing critical illness neuromyopathy, and that's going to prolong your weaning from the ventilator. So this becomes a very tricky affair in multifactor. Everybody knows in a straightforward sepsis, septic shock case, it will be critical illness neuromyopathy. The problem here comes in that all the factors which will take care for critical illness neuromyopathy will same be contributing in
muscle weakness.
In the muscle weakness and the neuromyopathy, and that will be easily be confused with the intermediate syndrome, and then if it doesn't wake up and doesn't work up, it will be a problem. Second thing, because it's a 6-7 day, her BMI is 36, she's a fat lady, there is high chances that the organophosphorus thing is still coming. Remember, if they have taken the powdered form, non-dissolved form, it is much more toxic than the liquid form. Sometimes they come just with the powder, they will just gulp the powder and come, especially with the end-stage kind. That's why it's an elderly female, it's a typical thing which you will get it. The things you need to avoid is all the medications that is going to affect your muscles and the neuromuscular things. That's why I specified that aminoglycosides, I said, so you should avoid those aminoglycosides. Definitely be cautious about colistin. Polymyxin, it is again a borderline, but if it's infective thing, then you have to try to use the alternative antibiotic which is there. Avoid statins that to induce, avoid azoles that is again going to potentiate the effect of the statins. Beta blockers and everything are going to counter your atropine effects. So that is again you have to take care, continue anti-platelets. So we are so much used to demarcate our urban disease and the rural disease. But when the problem comes when both of them come together. Because by second week, it is easy that we will be getting a sepsis, septic shock, secondary infection. It is very quite common at our place, right? So you have to keep all these things in mind. As you do for critical illness, neuromyopathy, strict glycemic control and blah, blah, blah. The same thing, bit more cautiously you have to apply. Complicated by your intermediate syndrome and extended organophosphorus issue, because her BMI is very high and there is a likely that she is going to continue sickness. That's what I wanted to convey.
Yes, sir.
That's all.
Dr. Pragyan, yeah, do you want to like
Yeah, I'll add up. I think I'll take up the question.
Like how to like go about like this, especially they are third year DrNB students. So
Correct.
what do you observe out the presentation, and what are the different tips that they can follow to perform better in exams?
Great. So I'll take up the question asked by Kaladhar. You only asked, but how will you prognosticate? So prognostication in ER is very important. The answer to that question is the onset of acute coronary crisis, duration of acute coronary crisis, intermediate syndrome, and requirement of mechanical ventilation. These three factors decide how bad is the patient is. So if patient is requiring mechanical ventilation within few hours of admission, definitely patient is very sick, prognosis is very bad. So you have to tell like that. Coming to exam point of view, it will be classically very practical oriented actually. So when we asked AP poisoning is coming in, if you're not telling about personal protection and decontamination, then you are in a back seat. So make sure to tell about personal protection and decontamination. And atropination, Paradoxim theory and practicality should be discussed. What are the evidence around paradoxim should also be known to you. Number 2. Number 3 is definitely, as Dr. Anand elaborated, whether there is any coexisting poisoning, that should also be considered. Intermediate syndrome should always be thought of, and of course all DNB students will go through the second week of somebody acquiring a hospital-acquired infection, how to deal with it. As very important is to delineate between intermediate syndrome or any critical care illness neuropathy. OP poisoning is just a cakewalk. I think that's all from my side, Dr. Kaladhar.
Yes, sir. Yeah, Dr. Anand, sir. Yeah. Do you want to add anything, sir? Final comments?
No, I think I've said a lot.
Yes, sir. Thank you for the brief overview, especially. Okay. Thank you, sir. I think we came to the conclusion of the webinar. So, Dr. Goutham and Dr. Veni, both of you, thank you very much for presenting, which has been helpful. I think it's been, I think nowadays, like the students are
Dr.
coming.
Kaladhar, you should thank this Dr. Kaladhar. One sec. Can I speak for a minute?
Yeah, Sriram.
Yeah, special mention of Dr. Sriram. He has been answering like hell. I think we should put up our hands together for Dr. Sriram. We have never stopped answering.
We can answer all the questions, something like that. Yeah. So Sriram, yeah, thank you for very active participation.
Ready for exam.
Ready for exam. Thank you,
Yes,
Dr. Anand. That is wonderful. Thank you, Dr. Anand. Wonderful.
Thank you, Dr. Anand, sir, and thank you, Dr. Pragyan. Yeah, being here. So thank you, Yashoda Hospitals and our digital and branding team for constantly providing the platform. Yeah, thank you very much. Good night, all of you. Thank you.
Thank you. Good night.